Good evening, everybody. Thank you very much for coming for our first oculoplastic session of MIOM. We are running a few minutes late, but I appreciate your attendance with us today. Our session title is Golden Keys in Lacrimal Surgeries, and we will have great speakers today who will give us a lot of critical knowledge on this issue. The first to present today with us is Dr. Ali Rida Radawi. Dr. Ali Rida is a consultant oculoplastic surgeon, head of the oculoplastics unit at Al Nahda Hospital, which is part of the Ministry of Health in Muscat, Oman. Dr. Ali Rida will be talking about the assessment and interpretation of clinical and paraclinical lacrimal tests. Please, Dr. Ali.
Okay. Thank you, Dr. Khalid, for the introduction. At the outset, I would like to thank Dr. Mohammad Al-Amri and Dr. Farzad for inviting me. Unfortunately, Dr. Farzad is unable to attend today's meeting and is surely missed. So I'll be talking on assessment. Assessment and interpretation of the lacrimal tests. I have no financial disclosures to make. So the initial step in the assessment of tearing is to differentiate lacrimation from epiphora. As we all know, lacrimation occurs due to stimulation of trigeminal nerve due to ocular irritation, while epiphora occurs due to drainage impairment and leads to overflowing of the tears. It is important to differentiate between these two conditions, as we know the management of these two conditions lie at the opposite end of the spectrum, one being medical, other is surgical. So a detailed history is must, as it aids in the assessment of tearing. Sometimes patients of dry eye comes with paradoxical symptoms of epiphora. However, no frank epiphora exists in them. So it is also important to rule out dry eye before we actually proceed towards the assessment of tearing. So a systemic examination pinpoints towards the different causes of tearing and help us in differentiating causes of lacrimation from the drainage impairment causes. So there are a number of eyelid and ocular conditions that can lead to tearing and which can be missed during a cursory examination. So that's why a detailed and meticulous journal external examination is must to rule out different causes. For example, trichosis, which is an important cause of lacrimation. Similarly, upper lid and lower lid entropion can also irritate ocular surface and lead to hyperlacrimation. Sometimes rare causes can be detected on everting the lid, like pyogenic granuloma or a foreign body causes lacrimation. It's going very fast. Can you slow it down, please? Yeah. And when a patient of ectropion comes, it should be examined carefully to see the eversion of the puncta, which can further exacerbate epiphora. A patient of facial palsy comes with epiphora may have multiple factors, like due to incomplete blinking, there can be lacrimal pump failure, there can be paralytic ectropion, or sometimes tearing can be due to crocodile tears also. So slit lamp examination starts with the examination of tear film. If we get a high marginal tear strip, it indicates some obstruction at the nasolacrimal system. Then you have to evaluate the puncta. Normally, on slit lamp examination, puncta should not be visualized as is directed posteriorly towards the lacrimal lake. In cases of paralytic ectropion or involutional ectropion, we should see the early eversion of the puncta, which can, of course, exhibit epiphora. And sometimes in conditions like Centurion syndrome, also there's early eversion of the puncta and can be missed if you have not done a careful examination. Then we have to look for whether the puncta is open or there's stenosis. As stenosis of the puncta can lead to epiphora, and there are various causes of stenosis. like inflammatory diseases like Stevens-Jones syndrome, ocular secretial pemphigoid, or it can be iatrogenic due to chronic use of glaucoma drugs, or even topical chemotherapy like mitomycin C and 5-FU can lead to punctal stenosis. Sometimes puncta is deliberately blocked in cases of dry eye with punctal plugs and can also cause epiphora. Then sometimes there are adjacent structures like caruncular hypertrophy or conjunctivocalysis can block epiphora leading to tearing. And of course, the inflammatory conditions like canaliculitis should be ruled out in cases of epiphora. So, after we have ruled out all the conditions, then actual assessment of epiphora starts with the inspection and palpation of the medial canthal area. If we see the swelling in the medial canthal area, which lies below the medial canthal tendon, it is usually a lacrimal sac swelling, which can present as a hypermic and tender swelling in acute dacryocystitis, while it can be diffuse, non-hypermic, non-tender in chronic dacryocystitis. Sometimes in cases of nasolacrimal duct obstruction, we see a large tensile swelling, which is because of the functional wall of Rosenmuller. If we see an enlargement of the sac, which lies above the medial canthal tendon, then it indicates a lacrimal sac malignancy and should be further evaluated. Then if in the presence of a swelling, once we do the palpation in the lacrimal sac area and there's a regurgitation of mucoid or mucopurulent fluid from the canalicular system, it is pathognomic of nasolacrimal duct obstruction and no further tests are required. So the clinical evaluation of the lacrimal system we start with a simple test like dye disappearance test, syringing, probing, or an endoscopic nasal examination. Dye disappearance test is a good test in children in which 2% fluorescein is instilled in the inferior fornix of both eyes and is further interpreted by various grading system. So grade 0 is when we see no fluorescein in the conjunctival sac after 5 minutes of installation of the fluorescein. Grade 1, we see a thin fluorescein marginal tear strip after 5 minutes. In grade 2, a more fluorescein persists somewhere between grade 1 and 3, while in grade 3, we see a wide, brightly fluorescent tear strip. So grade 0 and 1 are considered as negative and indicates a patent nasolacrimal system, while grade 2 and 3 are considered positive dye disturbances, indicate some obstruction in the nasolacrimal system. So after that, we continue, after dye disturbances, we continue with syringing. So lacrimal cannula is passed in the vertical and horizontal canaliculi. The most important step is the lateral traction of the lower lid to avoid kinking of the horizontal canaliculi and easy passage of the cannula into the lacrimal canaliculi. So once the cannula enters into the canaliculi, irrigation is done and further assessment is done. So if we see the passing of the saline into the nasolacrimal duct, into the throat, it tells us that there's a patent anatomical system. However, if a patient complains of epiphora and there's a positive dye disappearance test, it can be a functional obstruction or a lacrimal pump failure. In cases of partial NLDO, there is simultaneous regurgitation of tears from the opposite canaliculi and some of the fluid is passing into the throat area. In cases of canalicular block, it's sometimes difficult to pass the cannula into the canaliculi, and on irrigation, there's a regurgitation of fluid from the same puncta. In cases of common canalicular block, we see the regurgitation of clear fluid from the opposite puncta without any distension of the lacrimal sac. While in NLD obstruction, there's regurgitation of mucoid or mucopurulent fluid from opposite puncta with distension of the sac. So there is a condition in NLD obstruction in which sometime on irrigation, we don't find any regurgitation from the opposite canaliculi, as well as nothing is going down the throat. So this is a condition in which there is an NLD obstruction with functional wall of Rosenmuller. And of course, there is distension of sac on irrigation. So following syringing, if we are suspecting a common canalicular or a canalicular block, then we go for a diagnostic probing. If puncta is stenosed, Then it should be dilated with punctum dilator, followed by a probing is done with the Bowman's probe in a similar fashion by giving a lateral traction to the lid to avoid any horizontal kinking. So if we get a hard stop on probing, it indicates the probe has entered into the lacrimal sac, and we are touching the medial wall of the sac and lacrimal bone. So it indicates a patent upper canalicular system, and a diagnosis of NLD block is made. However, if we get a soft stop, it tells us the puncta is prevented from being entered into the lacrimal sac, and there's some blockage at common canalicular level, and a diagnosis of common canalicular blockage is made. Sometimes we feel a resistance on passing the probe at the canalicular level only. Then this distance should be measured by holding the probe at the level of puncta, and should be measured directly on a scale which tells whether there's a canalicular blockage or a common canalicular blockage. Then nasal endoscopy is of course must before we are planning a lacrimal surgery. It rules out various anatomical variations which of course interferes during our lacrimal surgery, as well as they exclude different intranasal pathologies which can contribute towards epiphora by blocking the nasolacrimal, blocking the NLD opening at inferior meatus. So we see in the majority of the cases with a detailed history and good clinical evaluation, we can make a diagnosis. However, in small percentage of cases, we need some certain paraclinical tests. So dacrocystography is indicated if we have a dacrocystitis in cases of a previous craniofacial trauma or a surgery, in cases of failed DCR, a suspected lacrimal sac malignancy in case of dacroliths, or a functional obstruction of the nasolacrimal system. So in dacrocystography, a radiopaque dye is injected in the canalicular system, and a magnified radiological image is seen to assess the anatomy of the nasolacrimal system. So you can see, for example, in this case, this is a case of a post-DCR case which shows epithelialized tract with the dye going into the nasal cavity. An additional film should be obtained after 10 minutes in erect position to evaluate any dry retention if you are suspecting a functional obstruction. Using computerized digital subtraction DCG, superior images of the lacrimal drain systems are obtained, which helps in a better assessment of the anatomy of the lacrimal system as well as the areas of blockage. Dacrocystography is rarely indicated, of course, in function and LDO. It has an advantage over dextrocystography that it assists tear drainage under more physiological condition. A technetium-99 radioactive tracer is delivered to conjunctival sac with a micropipette, and imaging is done at a rate of 10 seconds per frame for 15 minutes, and the images are further assessed. So if you see at the right-hand, second image at the right-hand corner, thus you see a solid arrow indicating the radioactive tracer entering the lacrimal sac area, while on the left side, no radioactive tracer is entering the nasolacrimal system. And if you see the last image, again you see a dotted arrow showing the radioactive tracer entering into the nasolacrimal duct and ultimately entering into the inferior meatus. So after 15 minutes, if you can find a radioactive tracer in the nasal cavity, it indicates the patent system. When on the left side you see no radioactive tracer can be seen, indicating a functional block. So last but not the least, imaging should be indicated in cases of dacrocystis with craniofacial trauma. For example, this is a child which come to us with after RTA showing bilateral orbital fracture with bilateral enlarged sacs. Similarly, it is also indicated in suspected neoplasias of lacrimal sac as well as nasolacrimal areas. This is a young lady which comes to us with a lateral dystopia and epiphora, and CT image shows a frontoethmoidal osteoma. So take-home message is a detailed history, thorough examination, and meticulous clinical and paraclinical tests when indicated clinches the diagnosis in majority of epiphora cases. Thank you for your kind attention.
Thank you very much, Dr. Ali Rida, for your presentation. We will have the questions from the audience at the end of the session. It's my pleasure now to introduce to us and to you all Dr. Yunia Arawati, who is coming all the way from Jakarta, Indonesia, consultant oculoplastic surgeon, vice president of the Asia Pacific Ophthalmic Plastic and Reconstructive Surgery Society, as well as the president of the Indonesia Oculoplastic Society. And she will be talking to us about what are essential and new in pediatric epiphora. Doctor, please.
Thank you for introduction, moderator. And first, I would like to thank for organizing committee who invite me in this nice meeting. And this is the first time I'm coming to the Dubai. It's a nice country. And today I would like to share with all of you with the title of what are essential and new in pediatric epiphora. Can I use my slide? Okay. Yes, thank you. There is no conflict of interest for this presentation. As we know, the nasolacrimal duct obstruction in pediatric is a rare case and could be related in the some syndrome. And non-canalization of the inferior caudal of the end of the duct usually present caused by persistence of membrane of the valve Hasner. But it is spontaneous resolution. It's around 90% case of effect in children in the first years. And the female predominantly at least 70 until 80%, and unilateral 80 until 90%. With a median age can happen 12 days until 40 days after birth. For the clinical manifestation, the parents bring the baby or the children with the complaining of epiphora usually is persistent, and there was a mucous and or mucopurulent discharge. The fluid accumulate and trap within the lacrimal sac, and we can see in the ophthalmological examination there is a bluish lesion in the medial canthal. And with the pressure is applied over the lacrimal sac, they can have a reflux of mucoid or mucopurulent material from the punctum. And we need the additional examination like a fluorescent dye disappearance test or Jones 1 dye testing with using the fluorescent at the fornices. We can see the 5 minutes with the cotton tip in the nasal cavity. If there is no fluorescence at the nasal cavity within the cotton, maybe we can assume there was any blockage at the excretory lacrimal system. And sometimes we can use the ancillary tests like USG, MRI, or the CT scan. And the classic for the CT scan, we can see the cysts at medial canthal mass, nasolacrimal duct dilatation, and continuous submucosal nasal. In the fluorescent dye disappearance test can be helpful to in confirming the diagnosis of the lacrimal duct obstruction. And for the management, of course, first treatment is conservative because more than 80% case with the children, it can be resolved by the treatment Usually we can use the lacrimal massage, like trigger massage, or we can give it the antibiotic for some cases. But in 20% cases unresponsive, sometimes we need to do the probing. We can do it twice if it is not working, and then we can thinking, is it necessary to do the surgical intervention? The factor implicated in failure probing usually is caused by improper technique or late age of the probing, complex nasolacrimal duct obstruction, inferior turbinate hypertrophy, and associated with the nasal pathology. Kushner reported that the lacrimal massage performed with the occlusion in the common canalculus and firm downward pressure in the lacrimal sac was effective than comparing with the gentle massage or no massage. In dacryocystis is associated with the neonatal ODNL should be treated with the systemic antibiotic or urgent probing of the nasolacrimal duct with attention to the need to marsupialization of the membranous kiss of the distal at the end of the duct. The surgical intervention, usually we can use the balloon cystoplasty, or if we can see the surgical marsupialization at the lacrimal kiss, we can do the endoscopic or external DCR with the silicone insertion into tube insertion. With the endoscopic DCR, I think now it has been a success rate approaching that the external in children range 82% until 94%. I think endo-DCR have a good success with preferably because there is no scar. We don't disturbing the medial canthal tendon, and we can see the identification, the intranasal abnormality and less bleeding, and we don't disturb the blink reflex. The complication with ODNL in the children, I think, usually can cause dacryocystitis or lacrimal sac abscess. The common complication is dacryocystitis because the inflammation of the lacrimal sac can cause the persistent accumulation since there is an obstruction of the nasolacrimal duct. In examination with the complication, dacryocystitis, we can see the edema, redness, and painful over the medial canthus. And then it can be accompanied by the fever. I think the diagnosis, basic and a clinical examination, then sometimes we need to do the ancillary tests. I have a patient with girl, 2-week-old, and they came to the first ophthalmologist with complaining of bluish lesion on the medial side of both eyes, and watery eyes, and a serous discharge. And the first ophthalmologist give it the antibiotic and give the massage. 1 week later, 3 weeks old, the bluish lesion in the right eye is completely resolved, but in the left eye, we can see the lesion started to get bigger from the mass. And 1 week later, the mass become bigger, 1 centimeter diameter, and the doctor give it antibiotic and anti-inflammation and consult to the plastic reconstructive. 1 month later, the patient came to me, and we see the size more bigger at twice. Now is 2 centimeters diameter, and we did the CT scan orbital. We can see in here the dilatation of the nasolacrimal duct. And when we saw the lacrimal bone is very thin in here, and the mass bigger, I think at least similar with the globe. And there was hypodenslation on the medial canthal region and connected with the nasolacrimal duct. We suggested with the dacryocystosis not only maybe valve of Hasner problem, but the valve of Rosenmuller can persistent. In here, we didn't only diagnose with this patient with the ODNL with dacryocystosis, but this baby had a palatoschisis, polydactyly, and anorectal malformation, and inguinal hernia. This patient with the syndrome, not only the lacrimal system problem. And here, when we did the surgery, to take out we do the incision in the lacrimal. When we do the incision of the nasal mucus and we look at the CT scan, the bone like lacrimal sac is very thin. We can incise very well with the knife, and then make it the flap easy. And after that, after we make sure there is no any blockades anymore, we do with the probing to make sure it dilated the punctum, and then when we look, there was we can go to the nasal and inserted the silicone tube. And after post-operative one day, there is slightly edema in the medial canthal, but 1 month after operation, I think there was a completed resolve in this baby. I think, thank you for your attention.
Thank you very much, Dr. Arwati. Now it's my pleasure again to introduce to the audience the immediate past president of the European Society of Ophthalmic Plastic and Reconstructive Surgery, Professor Francesco Leoni, consultant oculoplastic surgeon, who is currently working in Rome, Italy. He's an academic professor in Pavia University, and he'll be talking to us about the management of post-operative tearing. Please, Professor.
Thank you very much to all of you. It's a real pleasure to be here in Dubai, which is a wonderful place, and try to Great. So I have no financial interest for this talk. And actually, it's a difficult topic, because when we have post-operative tearing, we say, okay, of course, something was wrong, so what we have to do about it. So the first thing is to realize which is the aim of DCR surgery. Of course, relieve the epiphora from the nasolacrimal duct obstruction, and relieve stickiness if mucocele or dacryocystitis was present, and avoidance of complications such as skin scar or loss of lacrimal pump if we had chosen an external approach. Of course, this doesn't happen or should not happen with an endonasal approach. And I mean, these diagrams were made by Jane Olver, and I just wrote with Jane Olver a chapter on the Zopper's book about this topic. This is why I'm using her diagrams, which are very clear and very good in my opinion. So how do we assess if our DCR was successful? The patient should be symptom-free. It means that the patient should not be watering and should not have any stickiness. We do probing and syringing of the upper and lower canalicula with saline to assess that both are patent. And what is interesting and helpful is an endoscopic inspection of the intranasal ostium and perform the functional endoscopic dye test, as we will see later, that can be very useful to assess that our rhinostomy is correctly patent. And another big question is, when do we assess that RDCR was not successful? When do we assess failure? We can suspect something when we have an early persistent watering with tubes in, that is at about a couple of weeks following surgery, so the patient should already be symptom-free. Then there might be recurrent watering after tube removal, that is 3, 4 to 8 weeks postoperatively, or we may have later failure at about 6 to 12 months. So my advice is to check this patient about 9 to 12 months after surgery to be absolutely sure that everything was okay. What do we do? Are we desperate? No, we just have to assess very carefully the patient to try to understand what went wrong. We always have to think systematically from the eyelid, then puncta, then distal lacrimal system. So, of course, we have to assess again the eyelid function, the punctum position, perform the dye test, syringe and probe both canaliculæ, as I've mentioned. Then we have some additional tests. So, if we have microendoscopy, we can use microendoscopy. We'll see it later. Nasal endoscopy is a must, I think, when there is a failure. And we have heard from our first speaker about imaging, which is always debated. What do we do with nasal endoscopy? We can identify the changes in the nasal mucosa induced by surgery. We evaluate the effectiveness of the rhinostomy. And this is why it's so important, the functional endoscopic dye test. And most of the times we can identify the causes of failure. And as you can see here, you can have, of course, a scar mucosa, or you can have a partially patent rhinostomy, but I mean the patient, like in the right picture, is still complaining of symptoms. And what about imaging? I mean, the first speaker told us a lot about imaging. It's always debated, so there are some surgeons who advocate imaging in every lacrimal patients, other surgeons who would do it only in peculiar cases. I think it's advisable to have imaging in most of the endonasal cases. Just we are never so sure if we just see the bone before the lacrimal sac about malignancy, but of course if we have to perform a redo surgery, then this is mandatory if we think we might have missed something. So if there is persistent pain on the site of the rhinostomy, or there is abnormal scarring, then we might think we might have missed a malignancy. Or, of course, if there's something inside the nose, like in this case. And what is interesting is if the patients complain of persistent sinonasal symptoms, a DCG might be helpful. These images are borrowed by the very interesting paper by the Moorfields group, Hannah Timlin and Daniel Ezra. I'm quoting because, I mean, they're excellent lacrimal surgeons, not only because they are very good friends. They just, in this patient, they, with the DCG, they show that sometimes a wrong rhinostomy can be made not into the nasal space, but into the sinuses. So this is one thing that might happen sometimes. Why there was a failure? So we have different causes. Of course, the first thing is inadequate surgical technique. So we may have a small high ostium. This is the typical SUMP syndrome. So there is patency at syringing, but the patient is complaining about both epiphora and a sticky eye. Or there might be a low, small ostium, so we have a functioning DCR. But all these cases are prone to scar a little bit later because there is a small, low rhinostomy. Another big important thing is bleeding, intraoperative bleeding. So always we have to tell our patient to discontinue aspirin for 7 to 10 days before surgery, clopidogrel for at least 5 days, and always discuss with the physician the protocol of interruption of an anticoagulant drug. And we do external DCR on LA, or even endonasal on GA, we always have to check intraocular pressure of the patient. And sorry, not intraocular pressure, the pressure of the blood pressure of the patient. And another very important thing is to discuss the protocol with the physician if they're taking even new anticoagulants, because most physicians would say, okay, you stop it for a couple of days and you start again immediately after surgery, which is absolutely wrong, because if you do orbital or lacrimal surgery, you should discontinue anticoagulant drug the day of surgery and the following day, to be sure. Then you have all the other causes determining epiphora that some might intervene later, or some, as beautifully shown in our first talk today, might be there before the DCR and might have missed. So a missed upper canaliculatis, conjunctival chalasis, hypertrophy of the caruncle, meibomian gland dysfunction, a previous blepharoplasty, lower lid blepharoplasty with a lacrimal pump, or previous punctoplasty, or you can see top right cheese wiring of the tubes, or these causes can determine postoperative epiphora. High-risk cases, all these cases. So we have to discuss with the patient that we have a systemic pathology, when we have an abnormal mucosa, or when we have previous nasal surgery. These are difficult cases, and failure is a little bit higher than the usual 90% that we tell the patient. Then there is the big chapter of canalicular obstruction. Have we missed a previous canalicular obstruction and we have forced with our tubes while performing surgery? Or did we determine a canalicular obstruction with our surgery because we didn't manipulate with accuracy the two canaliculi? This is a big question. How do we solve this? We have, in my idea, to clearly say and notice the level of the canalicular obstruction, because the approach will be different. So we'll see it later. Then, of course, with the nasal endoscopy, we can say see an inflammatory granuloma, scarred ostium, or obstructive membrane. Of course, these are all cases of failure. Which is the rationale of redo DCR? Would we choose an endoscopic approach or an external approach? We can choose both, depending on our expertise. Of course, we have to fully open the sac, remove the bone and the scar tissue, and with the endonasal approach, we can create a wider nasal space if need be. When we choose an external approach, then let's try to shape big anterior flaps, because in this case we'll open the sac, and with the sac remnant and with the remnant of the nasal mucosa, we enlarge anteriorly the rhinostomy, and we do at least big anterior flaps. There will be less scar tissue, and the chances of a good outcome, even with the redo, will be very high. What do we do if we have a post-op canalicular obstruction? So do we always do a Lester-Jones tube? In my opinion, yes, if we did DCR with retrograde intubation for proximal canalicular obstruction. In this case, most of the times we had to shape a false opening because there was no punctum. So we have a nice bed with our previous rhinostomy to place with endoscopic control a Lester-Jones tube. I prefer this one with a flange. With a silicone flange, what we have to do with the endoscopic control is to use the right length of the tube so that the flange is at least 3 millimeters distant from the lateral nasal mucosa, to avoid that when there is inflammation, postoperative inflammation or any other cause, the inflammation of the nasal mucosa would tend to push the tube in, and so avoid migration of the tube. Things are different when we have other kind of canalicular obstruction, because we can use very easy way like the self-retaining intubation set if we have one patent canalicular and just, for example, a lower mid-canalicular obstruction. And I prefer this device
to bypass surgery. Thank you for your attention.
Thank you very much, Professor. Please, we'd like now to open the floor for any questions you have for our panelists. If you have any question, please raise your hand. We'll get the microphone to you.
Hi, this is Dr. Milind from Hyderabad, India. My question is to Dr. Shah. You showed that one case where there was a blind pouch. Was that a diverticulum? What was your opinion? What was that?
Yeah, that's a great question. So as I show you another DCG, even though it's not that patient's one, but sometimes I found that kind of lower end is dilated. So I don't think it's a true diverticulum, but some patients has that kind of normal variant of lacrimal sac. So what I wanted to say was when you do the dacroendoscope, so you have to observe, observe while moving backward to make sure you are in the right track. So yeah, that's my.
Thank you. Any more questions? I'm sorry.
Thank you. This is a small question to Dr. Arawati. I think you mentioned the child with the dacryocele, and you said, in addition to the antibiotic drops, you gave artificial eye drops, isn't it? As well, I didn't understand why. Is it the artificial eye drops, the lubricants given empirically or for a purpose?
Okay, thank you. Actually, the tears doesn't work. I agree with you, but this is the previous doctor give it the artificial tears. I think for this case is not useful. I agree with you. Thank you.
Okay, thank you.
Excuse me, a question for the pediatric epiphora. At what age you begin to do the probing? And the second question, at what age you do the DCR in pediatric epiphora? And the third question, why you didn't do only the probing for dacryocele? I think it's enough to drainage the dacryocele without doing the endonasal procedure.
Yeah, thank you for the question. Yes, I think in my case, the patient came to us with a large mass, and then I agree with you, in patient with pediatric, if we already did the massage with the Krieger massage, maybe for a few months, yeah, less than 6 months, I think. I agree. The patient should be do it the probing. We can do it the probing twice, yeah, until less than 1 year old, yeah. Usually, if the patient came to us very late, sometimes the probing not useful, but at least we're trying to do the probing first, yeah. But in this case, the patient came to us with a huge mass, yeah. I think the increasing so bigger, yeah. When we are looking from the endoscopic, the marsupialization is so easy, I think, to do only the incision for the mucous nasal doesn't have a false root, maybe if we do the probing in this case. And then I choose the nasal endoscopic to treat this case. Thank you.
Yes.
Maybe you have any opinion?
No, it's okay. I mean, I think the question was you were thinking about the proper age to perform a pediatric DCR. Yes, I mean, in my experience, I published a small series about pediatric DCR, and I had a couple of unusual complications in children. One, I mean, it's very easy to get swollen because they just, if you do a big rhinostomy, you might have emphysema, which is more common than in adults, just because when they wake up after anesthesia, they shout. You always tell the patients, the adult patient, not to blow their nose. So this is one complication. And I had a couple of agenesis of the upper canine, which is very rare, because if you ask your friends who are dentists, they will say that probably in their life they will never see one. So probably because, I mean, the gem of the upper canine is very close to the rhinostomy. If you are quite enthusiastic like I am with a big rhinostomy, then this might happen. So what I advise my young patients is not to do it before the age of 3.5, 4, 4.5, something like that. But of course, in a case like this, you have to go. There are some exceptions. So I think that was absolutely right.
So one question to Dr. Hu. First of all, thank you for the informative presentation. Secondly, in the way that you open the obstruction by transcariniculus endoscopy, do you use laser or drill in those cases? And which one do you prefer?
So could you repeat the question?
How do you open the obstruction?
Oh, yeah.
Is it by using laser or drill?
Yeah, it's good question. So I usually use the endoscope itself to recanalize the obstruction site. And sometimes I use an angio sheath because we usually use the 18 gauge angio sheath. We cut it and insert the endoscope into the angio sheath. So when we do the endoscopic procedure, we can precede the angio sheath first. So we can use that to recanalize the obstruction site, or sometimes we send the angio sheath first and then follow the endoscope to get in the right track. So yeah, we use both of them. And so as you mentioned, so there is so when we use an endoscope, for example, for 1 year, so we have to change the endoscope because there are some trauma, minor trauma on the surface of the endoscope. So that would be another issue. Yeah.
A question for Dr. Sa, please. While you're doing the transcanalicular endoscopy, why you didn't think about putting a silicone tube to get good results for a long time? Because I don't know if the follow-up, for how many months you do your follow-up. This first question for Dr. Sa. The other question for Dr. Francisco. When you inject the Botox in the lacrimal gland to decrease the secretion, how many units you put in the lacrimal gland? 2 units, 5 units? Just 2 questions. Thank you.
Yeah, I think that's a very great question because long-term follow-up is very important, this kind of minimally invasive surgery. So I agree with you, partially agree with you. So we follow up more than 1 year usually. So far, the success rate was pretty good. So the purpose of using lacrimal endoscope is not completely replace the endoscopic DCR. So I still do endoscopic DCR for patients who failed with this kind of minimally invasive surgery. But I found in many patients, I used to perform the endoscopic DCR. they are pretty good in long-term follow-up after this minimally invasive surgery. I think that is good point. And another thing is, compared to blind probing procedure, so that's why I show you the false passage patients. So it's very difficult to get the right track after having some false passage inside. So using the endoscope, we can sure we are in the right track and we can precisely recanalize the track. My Japanese colleague, he found almost 20% of people who underwent the blind procedure, so they had a false passage inside it. So that is another supporting evidence we use the Decker endoscope.
Okay, thank you.
Quick answer, 2.525. There are two reports which I quoted, and basically that's what they do. There is a report from the British Society, which is quite interesting. You'll find all the information. Okay, and you can inject transpalpebral or directly under the conjugal.
Because I usually do 5 units,
yes, 5.
And it gives a good results. So for that reason, I asked if there's maybe a special criteria for injection of Botox. So usually I do 5 units, and I get good results in the Epifora for 2 to 3 months.
Yes, you can start with a little bit less, and then you can re-inject. Thanks.
Thank you.
Can I add some comment? So I also published the paper about the lacrimal Botox injection. So personally I use a 3.5 unit. And so I found in case when you try to expose the lacrimal gland, if it is very hard because of the horizontal tightness or something. So in that case, I found there is a good chance to have a post-operative complication, such as some palsy or diplopia or droopy eyelid. So if you find it's very easy to expose the lacrimal gland, so it's very safe to perform the lacrimal Botox injection.
Thank you very much, our panelists, for this really lovely session. I hope everybody has enjoyed it. And I'd like to point out for our audience that in 5 minutes after the session has concluded, we'll be having our opening ceremony for MIOM in this hall. So I wish you all to enjoy the opening ceremony. Thank you very much for your attention. Appreciate it.
رغم هيك هدول كلهم فاشلين، يعني ما شفت مريضه الا اذا كان هو اصلا عندها مثلا تضيق نحن دمعيه السينوس شيء شيء ثاني. بس انه انا فضلت عم حط الانبوب وبتركه فتره وبرجع بعدين بسحبه وهيك بعدين انا هني شوف من فكره، يعني هو يعني فهمت منه